Welcome everybody to our Zoom meeting this morning. We're going to cover a bunch of stuff here, kind of different stuff, but we're going to put it all together for you. We are joined today by Dr. Dana Maxwell, who actually you'll recognize because she did a bunch of voiceovers for the OB simulation as well as one of the videos for us. And she's going to stay as long as she can. I know she has an admission coming in and she's doing inpatient. So she took some special time out for us to kind of just hop on and see if she can give us some assistance on our debrief here for what we worked on when it came to the OB sim. So I'm just going to jump right in and we'll start talking a little bit about it. So today's morning, we're going to start talking about the OB sim, and then we're going to do some clinical updates for COVID. I want to make sure we touch base as we're seeing our numbers go up and we're seeing everything happen in the community. What do we need to do? What do we need to think about? So start off with just talking about delivery and neonatal resuscitation. The first thing I love to touch base on is what did you guys think of the experience, and was this helpful? Are we on the right track when it comes to sim? And I am ecstatic to say that essentially greater than 90+% of you gave us strongly agree about the quality of the teaching that we provided this time around. And so again, these are the things I like to keep following. I just want to keep getting this feedback and making sure we're still on point about what we're doing. Some of the comments that came back was that you guys liked the flipped classroom style, where we actually, well, not flipped classroom, but flipped technique, where we did teaching first, and then we went into actually talking a little bit more about the actually doing the sim. In situations where it's a topic where we don't regularly do stuff with it, that's gonna be a consistent teaching method that we used. However, when we have things that, it's kind of common as part of our practice and it's just really honing and fixing little minor things about our practice, then we'll probably do full-on simulation. So you should expect coming up here soon that the next quarter will probably just toss you right back into doing a run and then debriefing after the run. So that'll be coming back again. So we're just picking and choosing the best techniques for teaching for the situation involved. Now, the key points I want you guys to focus on with this simulation, and I'll ask Dana to chime in when she's ready, is these 5 key points. To be ready for the badness, to remember the maneuvers that we talked about, keep in mind the 4 first steps after birth. Think about neonatal resuscitation and what your key is. Heart rate is the key. And last but not least, I am going to take a moment to talk about resource management. So first of all, let's be ready for the badness. Call your friends, call your uncle's friends, call people to come and assist you, right? So this is not something that you do on your own, and make some teams, right? So I think one of the classic things that a lot of us talked about was having a maternal team and a baby team, right? So a neonatal resuscitation team ready to go, and then assign some tasks. Have people know what they're doing as they're hitting the door, and think through your overall approach. So when I say thinking through about your overall approach, remind yourself about what you're getting yourself into. As the baby's coming out, the head is crowning, then the head goes into extension, and then there's external rotation. You should expect these movements to occur. And as these movements occur, you are going to put your hands on the side of the baby's head and you're going to assist the delivery of that anterior shoulder and that posterior shoulder, right? And of course, we will not drop the baby. Bad form to drop the baby. They're slippery, they're nasty, but let's try not to drop them. Dana's nodding like crazy. I think this is one of those challenges that we always have. Go ahead, Dana.
Yeah, they are slippery, and firm grip. A towel is helpful too. And getting them right onto mom as soon as you can, just to make sure they don't fall.
I like that plan. So, of course, we're always worried about the scarier deliveries, which are a little more complicated. So don't forget your maneuvers. The classic being the Mick Roberts maneuver that we talked about. The kneaded chest position is kind of what we think about. And the conceptual idea here is that we're increasing the AP diameter. And so that resolves so many of our dystocias. So in our situation, that's going to help us a lot and give us lots of benefit. And of course, you can think about using suprapubic pressure also, where you're putting pressure and closing up that angle so that that fetal distance becomes shorter between the fetal shoulders, so you can actually pass the shoulders a little easier. So both good approaches to actually moving towards this. Again, do not apply fundal pressure, because if you start applying fundal pressure, that's not going to help you. It's going to go the opposite direction. The next concept I wanted to hit on is, as you've delivered the baby, like every time we've talked about this is kind of one of those important concepts, is that that there's certain things that you're going to do immediately after delivery. Okay. And these are those 4 steps. And this is like almost should become a mantra for you if you can, is dry and stimulate, position the airway, clear the secretions, and warm and wrap, right? Just one after another, boom, boom, boom. A lot of us do it innately, but having it kind of programmed and thought through over and over again, that this is our first 4 steps, makes it really easy for us to be on top of it and to understand what we're going to need to do next. As we go from that point, then we have to make some tough decisions, right? So after the delivery of the baby, and we've done all the different 4 key steps that we want to do, the next question is, do we do skin to skin with delayed cord clamping versus some sort of intervention because the baby's not doing well, right? So this is that fundamental branch point that Dr. Maxwell just kind of referred to us, is that, hey, if we can put baby on mommy's belly, let's do it, right? And I know in our lecture, Scott touched on that there's tons of benefits that you have when it comes to actually doing delayed cord clamping. We have this in our lectures themselves too, where delayed cord clamping is giving the baby tons of benefits. But there's situations where we have to be cognizant of the fact that we probably shouldn't be doing delayed cord clamping. Now, right now, the AHA with the neonatal resuscitation group is working specifically on this question, because after we were getting this going, I asked a couple of questions on the AHA level, is when should EMS do delayed cord clamping? And everyone's kind of looking at me, they're like, we've never made a recommendation on that. And so I'm like, hey, would you guys mind responding to this and actually having a discussion about this? So hopefully soon we'll have a little bit more impact and information about what kind of caveats should we be thinking about, and what should set us off to say, forget delayed cord clamping and go straight to resuscitation, right? And that way a little guideline there would be really helpful for us. But for us right now, probably the best way to think about it is this. Think about it based on your heart rate. You deliver a baby, and you have 2 major base points that you want to look for, that heart rate of 100 or a heart rate of a 60, right? And both of those are really bad signposts in general. But anytime you're thinking that you have a baby who has poor heart rate or just not looking right when you're first seeing the baby come out, we're thinking intervention. Delayed cord clamping may need to be a hold there, because if you're going to resuscitate this baby, you may well need the room. Dana, you've seen a lot of these babies who are having a really tough time as they're coming out. Anything else you'd suggest with that situation?
Just dry, stimulate, and suction. And don't be afraid to be a little bit aggressive with suctioning sometimes, but really drying, stimulating them, trying to get them to kind of cough, breathe, cry, all those things to kind of help, if you can, avoid having to escalate care.
Yeah, piss them off as much as you possibly can in that first minute, so that we don't have to do the intervention piece. But if we do, keep in mind your neonatal resuscitation algorithms, right? So dry, stimulate, all those fun things are right here on the front aspect. But then once we see an aptic or gasping child who may have a heart rate below 100, start doing our intervention. Start thinking about positive pressure. Start thinking about monitoring your heart rate and your pulse ox, and consider looking at labored breathing. If you're starting to get if you're still below 100, check for chest movement. Think about the ventilatory corrective steps and whether or not we need to intubate. That's a reality here, that we may have to intubate the child. And the worst situation that I think none of us are wanting is that child with a heart rate less than 60, where we start thinking that if I haven't intubated them yet, I need to intubate them. More so, I got to start thinking about doing compressions, right? This is the time that the compressions are what's going to save this kid's life as we start doing the rest of the work we need to do. And these cases are realities in our space. Oftentimes there'll be preterm deliveries where we are not expecting this to happen. And so this can happen. This can be a reality. But keep in mind, you have some really great friends. Number one, breathing problems equals bulb suction. Just like Dr. Maxwell is just telling you here, guys, remember to do the 4 key steps, and bulb suction is part of it. And second, if you're seeing breathing, labored breathing or cyanosis, start the supplemental bag valve mask. Get it in there and start doing what you need to do. And of course, if you need to do compressions, go and do those compressions such that you resuscitate these kids as soon as possible. Last thing I want to touch base on in this area is resource management. So one of the things that a lot of us struggled with in this discussion wasn't the key aspects of the delivery and looking at our key 4s. You're noticing these key 4s keep popping up. Every single time I'm talking, those key 4 things are always there, right? But then if you have this baby and you've decided that I can't do delayed cord clamping because they're struggling, or they look really healthy, then we have to make another decision, because we're not at the hospital. Our decision has to be resource management. So if you have a healthy kid and mom and baby are together and everything's happy and people are crying and very happy, let's use one. We can think about using one unit, getting mom and baby to the hospital together such that we're not separating them. But there are situations where you have this struggling infant and you need to be able to resuscitate them. You need to be able to do the things you need to do, intubate, compressions, all those kind of things. And let's be frank, having the baby between mom's legs in the back of a rig does not make sense for that situation. We're not giving that kid the best chance, right? That resuscitation team, whatever team you've assigned for resuscitation, needs to have the space and the ability to do their job, right? And that freedom may well mean two units, one taking mom, one taking baby. And when we've chatted about this, we all agree going to the same hospital is the right thing to do. If the baby needs transfer to Nationwide later, that's fine. But if you can get them to the same hospital where they have a neonatal resuscitation care unit and things like that, where they both can be taken care of, that is a great approach, such that they can close the loop and work with the family about what next steps after that is. Dana, any thoughts on that?
No, I agree. Trying to keep mom and baby together is key, especially for that skin to skin. That's going to help both of them. And I like the new edits you made to my slide with the little ambulance. I approve of that. So.
Thanks, I appreciate it. So more than anything else, those are our main focuses on the key aspects for the debrief for the OB. We're going to switch a little bit to COVID discussion. But while Dr. Maxwell's here, I want to open us up for any questions or thoughts here, interim questions that the group may have before she has to leave. I hope this was a good experience for you guys, a little bit more challenging. I think the mannequin was a great addition. So we have a little more experience. And frankly, guys, those kind of mannequins aren't available everywhere. So we're really glad that we have it for our training. So you will see that mannequin again. And we will be doing more deliveries. But I'm going to pass it over to Dr. Maxwell for any last thoughts or any questions from the group.
I was going to say, for sure, the mannequin's great. We don't even have access to that. So even when I was doing the simulation with Dr. Panchal, that was great that you had the opportunity to work with such a resource.
Dr. Maxwell, I wanted to ask a question. If you could touch on the threshold, of when the crews should be thinking about, an IV, probably an IO, and to administer epi in the resuscitation.
Ooh, that's a good question. I actually will pass it to Dr. Panchal, because I honestly mostly only deal with healthy babies. I would say, though, in general, just to have a lower threshold, because it's better to be safe than sorry. And Dr. Panchal, if you disagree, let me know. But I typically deal, if we deliver a baby, if there's anything that needs to escalate care, then we're calling backup in if we're not certain.
Yeah, and I agree. I think it's early, Jeff. I think essentially, if you have a kid you're starting to do compressions on, you really better be thinking about that. So obviously, our goals then are either you use the umbilical vein, or you use you could put an IO in, right? And now these little babies, IOs and little babies, all of it's crazy, right? All of it's essentially crazy. And at that point, you're even thinking, should I just give them IM epi, right? So there's so many different aspects you're trying to think of what to do. If you can even just get like one of our normal angiocats into the umbilical vein, just so you can actually give some epi that way, that's fine. Remember that that's not totally in our scope, right? So you're going to be talking to me if something happens like that. But frankly, if something that bad's going on, you're going to talk to me anyway. So do what you need to do, save this baby if you can, is kind of where we're at with that. The other piece I wanted to touch base on is I focused on our discussion today on heart rate, right? I really pushed the concept of heart rate. Captain Gano did a great job of talking about the pulse ox with you guys. And the reason being is a lot of times when we're measuring heart rate, we're using our monitors, which give us also a saturation. Remember, all the discussion that you guys had of open channels, which cause a mixing of blood. Within the first 5 to 10 minutes, a lot of these kids will be hypoxic. That'll be the mixing that they have before they close up. So those numbers that you see for the pulse ox, don't use that as your main goal of resuscitation. Use the heart rate as your main goal of resuscitation. Understand the physiology you're dealing with, because even we don't do screening for congenital heart disease till 24 hours later with the concept that these things are going to close, right? But every time we do monitoring, a lot of times we're getting that pulse ox too. So just be aware and keep in your mind your heart rate. The pulse ox is going to be lower and it's going to track up over time. So even by the time you get the kid to the hospital, they may be at normal sats by that point, just because things are closing so quickly. Cool. Dr. Maxwell, thank you so much for joining in. Have a nice day and enjoy your admissions.
Well, the admission, actually, I just realized you sent it to us from Maine. So
Right.
thank you.
You're welcome.
Bye.
See you later. Thanks. I want to switch gears, guys. We're going to talk a little bit about COVID. You guys know how much I love talking about this topic. I hate it, but it's part of our job, right? So here we are. Our numbers are still going up as we expected. When we look at our normal numbers, I'm going to consistently show these images, and someday I'm going to be able to show this whole track. So I'll show it 20 years from now and show the people that we actually paid attention to this. But one of the things I do want to show is here's our peak from the December time period, which was really high. You can see that our current peak is still rising. And the more concerning piece is that we've leveled off when it comes to our vaccination rates, and we're staying pretty level throughout Ohio. This is not Delaware County. In Delaware County, we're much higher. We're the highest, still the highest county in the state when it comes to vaccinations, but still something to be concerned about. So brother, single sister, uncle, cousin, tell them to get vaccinated right now. The Ohio State University ICU, we've used all of our ECMO circuits, every single one. So we can't put another person on ECMO. And our ICU is full to about 98% right now. And so it is literally one of the worst situations that we've had when it comes to high level intensive care unit care. And the vast majority, like I'm talking almost greater than 90%, are unvaccinated patients. When we think about crisis standard of care, are we there yet is really the question. And my answer right now is no. So this is the similar discussion we had back in March about, do we use crisis standards of care? And when I say crisis standards of care, this means, do we not transport people and things like that? Right now, we're still in usual practice. We need to continue doing appropriate PPE and definitely gear up for your COVID patients. We are still not at the point that I'm going to start using crisis standards of care, but I will always have communications with you guys about those concepts, okay, and what those would be. So still transport like we normally do. Now, one of the options we've always had, and that's still active, is our non-transport protocol. So I do want to take a two seconds to touch base on this. Now, the non-transport protocol is not our ability to make a decision that I am not transporting you. That's not what that decision-making process is. What it is identifying patients who would be okay for us to have the discussion and have the team discussion on whether or not they want to stay home rather than go to the hospital, because it's really not going to help them, right? So really, for that situation, you look at their medical history and see if they meet criteria, look at their vital signs, see if they meet criteria, and ask some fundamental questions. Is home care suitable for this patient? Are there appropriate caregivers available if they're needed to be helped? Does the patient have capacity to make the decision for themselves? Does the patient agree to not be transported? So they're consenting to stay home, right? And this is almost like an informed consent. You actually talk to them, right, and explain to them what you're doing. They have access to food, water, other necessities, and there's no other household members at high risk for complications. So this allows us the ability for somebody who is like, say, 97% SATs, they're looking good, they just have a cough, and they're saying, yeah, I'm worried about COVID. And you're like, yeah, you probably have COVID. Frankly, you probably have COVID. Your SATs are great, but you're going to be sitting in a waiting room for 7 hours to get told the same thing. You'd be better off being here at home with your family and quarantining yourself and getting better. That's a great situation to have this discussion. Now, do you have this discussion with somebody who's SATing 92%? Right? 92, 88%? No, because they may well have multifocal pneumonia, which is going to blossom up and be even worse and end up in our ICU, right? So we don't know those. We can't identify those patients well yet, but we know what their complications are. We know what the high risk factors are, right? And all of those things will help us identify those patients. So at this point, I just wanted to give us a quick reminder about that stuff and just kind of talk a little bit about that. I'm going to stop sharing screen so we can take some questions and things like that, and any concerns or thoughts right now on these topics. I know I covered a lot of ground. We're at 8:23, so I'm going to keep us open for the next like maybe 30 minutes, and we'll go from there. I see something in the chat. Let me open my chat. I'm a little slow here.
Hey, Dr. Panchal, will you touch on real quick with the cruise? You know, Columbus is, you know, on citywide but for these mild people that request transport and want to be transported, the more appropriate hospital for them so they don't go downtown could be the Grady or the Free State County.
Yeah, I think at that point we have to use our judgment a little bit, right? So let's be frank, a freestanding in that situation may be very reasonable. Somebody who's really well appearing, who has URI type symptoms, who has mild COVID type symptoms, they don't need to go to the mothership, right? Let's stay out of that ring if we can, right? And take care of the patients we can take care of. I see a question from EMS 6. Hospitals are full. If these people don't need to go, but they want to go, you want us still to take them. And I think that's a yes. Our mantra right now still is that we are still not ourselves. We are still not at standards of crisis care where we make decisions for other people, right? We're not there yet. Will I change my tune next week? There's always a possibility, right? So this is something that's very dynamic, and we are continually having these discussions between Director Fischel, Chiefs Cochran and Burgess, as well as Captains Keating and Gano. These are the discussions we have every single day and doing touch bases on to make sure that we're still kind of doing what we need to do.
Hey, Dr. Ash.
Yes.
When would crisis be? What limit are we looking for? Because I've transported more COVID patients in the last 4 shifts than I ever did when it was supposedly bad.
No, I completely agree. And I think a lot of that is because we have a lot more people getting hit this time, right? So the initial spawn was a lot of the hospitalized, but now we're getting a lot more people being aware and actually getting hit, especially the younger population. So I'm not surprised you're transporting now. Crisis standards of care is going to be a decision that we make with the health department, as well as with the what our run volumes look like, right? And what the hospitals are looking like. So I don't have like a line that I can say, hey, after 10 transfers per day, you're done, right? I don't have a line that I can say. And so it's a conversation that we have to have across the board, because once we start making decisions for patients, we're taking informed consent out of the picture. And that's actually a pretty serious thing, right? So we need to balance what we can do against allowing them still to have the ability to make decisions. And part of the decision-making process may end up being involving Ring Central and things like that. So again, a very active discussion. I am sorry, I can't give you a better answer. I try to as much as I can, but this is one of those things that I don't really have a good answer for you yet. Keith, thanks for the feedback on the sim. Appreciate it.
Dr. Panchal?
Yes.
Is it appropriate for, whether it's COVID related or non-COVID related right now with the hospitals the way they are, to inform them in our radio report for very non-acute patients that they are triage appropriate, or should we just let them make that decision?
That's a really great question. And I have not made a decision on that topic because truthfully, we have not done a medical screening exam, right? So classically, when somebody comes to the hospital, that triage nurse who's coming to evaluate the patient does what's called the medical screening exam, which is an EMTALA examination to basically say that, yes, I do believe this person can go sit in the waiting room, right? So that's really not our decision to make, right? So a lot of times, I think your heart is in the right place to be able to say to them, say, hey, yeah, I think this is okay. I think that they're going to probably be okay up there. In truth, medical legally, it is not our decision, right? So I think that you're dancing the line there between trying to be helpful and stepping in their space of a medical screening exam. Does that make sense?
Yeah, absolutely. It makes sense. And the reason I ask is because, COVID aside, we're still taking patients who, let's be honest, they don't need to go to a hospital at all, but they're insistent that they're going to a hospital. And, I recently was at Riverside and waited 55 minutes just to get in a room, and then another 25 minutes to get a nurse to come in to get report. And it was a patient who definitely could have just called their primary care physician, but they wanted to be seen quicker, and that's their theories on it. So,
yeah, no, I think at that point, I think the discussion, I think posing the question and even gently saying, hey, is the triage area available, right? So you can even generally say, hey, is the triage area available? Or if they ask you the question, feel free to answer the question honestly.
Thank you.
My pleasure. Oh, mostly experiencing multifocal pneumonia, or is there a wider range of conditions? Oh, okay. So the vast majority of our ICU patients are COVID right now, I'm sorry to say. And a lot of them have multifocal pneumonias. It ends up being that the ones who come in acutely end up being the ones who are, I'm sorry, I'm responding to Elena's question on the chat. So I got ahead of myself. So the patients who we're seeing often do have multifocal pneumonia who end up being intubated. The ECMO circuits we're using is generally for that purpose, right? So as these people become more and more decompensated, they're not able to ventilate or oxygenate appropriately. And so at that point, we have to put them on ECMO. The only place ECMO can be is in the ICU. So as we're filling those circuits and managing those multifocal pneumonias without oxygenation and ventilation, that's filling a lot of our spaces in our beds. And so of course we still have to put in the strokes, you know, that like they go to the NICU no matter what we say, because they have to get the 1 hour neuro checks, right? But it's been kind of crazy. Like I worked the other day and I had somebody who I'd normally put in the ICU and they ended up in a step down bed because there just wasn't ICU beds. And so we have these like kind of 1 hour check type things that have to be normally ICU level of care, which aren't going to the ICU anymore.
Hey, Dr. Rosh, it's Jude. Why in the world aren't we opening just COVID hospital centers where we just take COVID patients there instead of putting them in and dragging them to the hospital where healthy people are? I don't understand why the convention center was already set up. Why don't we just, you know what I mean? I don't understand this whole deal of why we're taking COVID patients to hospitals where they could be going to a center that just takes care of COVID patients.
Dude,
because
you are brilliant.
Nobody can work in them. They don't have any staff.
Yeah. So right now, Jude, we are bleeding staff at this point. And so the hospitals have looked at expanding staffing and beds and things like that. And one of the biggest concerns that they have is that because of burnout, so many people have walked away from emergency departments and things like that and working in those spaces. That's made it really challenging. The other piece is activating those spaces is also sadly a little political. And so there's balances that are occurring that unfortunately are not completely transparent.
So from my experience, if you pay somebody enough money, they'll go work it.
It's true. True. Let me see. I know you're seeing younger people with this. Do you have an age breakdown on the ICU patients? I don't. Off the top of my head, I don't really have an age breakdown on that. I think that's one of those challenging things that I'll be honest with you. The biggest part I have is not so much the age breakdown. It's definitely unvaccinated. That is like the big thing is unvaccinated. Age breakdown, obviously the older people are going to get hit hard. The younger people are also getting hit. And we're seeing more of the younger people this time than we did the first time. I missed one question. Thank you for reminding me, Keating. Are all COVID protocols in the EMS manager active? Yes, they are. And I believe they're up to date.
Dr. Panchal, to further answer the question about the breakdown of age, I don't know about your hospital particularly or Franklin County particularly, but the Delaware County Health District puts out those metrics. So if anybody wants to look, I shared as much as I could on the first arriving dashboard, but they break it down by age group and hospitalizations. Obviously, they don't say if it's just a med surg or an ICU bed, but they break it all down. Our local health department does.
Yeah, we are just seeing a lot more young people, which kind of sucks. I had this totally well-looking 20-year-old who came in the ED, and this was last week. He looks so good. And then I get the stats on him. He's 88%. I do a chest x-ray on him. He has this huge, ridiculous multifocal pneumonia. I'm like, this sucks. And he was just 20-year-old college student.
I think the most common age group right now was the 28 to 39, I think is what it was. Is the most hard to hit age group right now in our county.
Yeah. Cool. Well, guys, I hate keeping you guys on too long. I'm totally willing to stay and chat even more because I definitely have a couple more minutes. But I want to wrap up this main part. It's 8:33. So thanks again for hopping in. Thanks for all you guys' hard work when it comes to the OB Sims. We're keeping our skills up at the same time of dealing with all this craziness. As of now, we are scheduled for our fourth quarter training, which is going to be coming up as another sim lab experience. We, like with everything you guys are doing, we're going to keep trying to break up the monotony with other things so that we can keep our spirits up and kind of keep everything going. If at any point you guys are feeling overly duly stressed, feel free to give me a ring. I'm here for you. I'm glad to chat through this stuff because it's insane. And other than that, please go out there, take care of yourselves, take care of each other. And I will see you guys in 2 weeks or sooner. Thanks again, guys. And call Ring Central if you need any help. I'll stay on for a couple of minutes if other people have questions. And Keating, can you stay on? Because I have something for you.
Okay, sure.
Thanks, Oscar, as always.
Thanks. Appreciate it.
Are you back to work now, Glenn?
I am, yes. This week has kind of been my soft opening. So
Soft opening.
hey, 2 months off. I'm like, I can't just go back at it, dive right in with a screaming child at home. So I went for the soft opening approach.
I gave him no breaks. I started asking for stuff right away.
Yes.
Yeah.
Yes, he
Yeah.
did.
So I'm gonna call you a little bit later today, Jeff, because I actually pushed back on one of the things you asked him to do. Sorry.
You at what? I don't know.
What?
Glenn, you have to give me a head. Oh, I know what it is.
Yeah.
I know what it is. Okay. All
Yeah,
right, we'll talk about it.
Yeah. I'll
Hey,
call you.
Dr. Panchal, how are you feeling about Moderna vaccine booster doses for non-immunocompromised people like us? They're recommending 8 months now. Should we be executing that promptly, or how do you feel about it?
So great question. I think number one, we don't have too much data on the booster. We think the booster is going to be necessary because we are seeing breakthrough, but we don't know if what we specifically don't know is for healthy, normal people like you and I, if the booster is even necessary early on, or can we wait for a full year, right? Because that timing makes a difference between how many shots you have available, right?
Sure.
For the immunocompromised, no question. Because the immunocompromised population is kind of horrible because even when they're getting vaccinated, more than half of them are still getting infected. So they're getting hit hard. So if you have any family members who have the vaccinated and are immunocompromised, get them the booster. As for us, I have a feeling we are going to probably be in the early population to get boosters.
Gotcha.
And I don't think that's inappropriate.
Yeah, my wife's immunocompromised. She just got her 3rd dose, but
So Jeremy, you should get yours too. So talk to her
just because I'm around her.
Yep, exactly. And actually,
Awesome.
they're complying with that. So have the discussion because her exposure is you. So
Gotcha.
you should consider getting that shot done.
Sounds fabulous. Thanks, Doc.
My pleasure, buddy.